Thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request Professor Dr. Kavita Sachdeva to start this session. Welcome, ma'am. Over to you.
Thank you, sir, for giving me this opportunity. So, students, benign tumor of nose and paranasal sinuses is not very common, but still they contribute approximately 0.5 to 3% of all head and neck tumors. So, why this is important for you to know? So, first of all, what is a benign tumor? So, a tumor is used, the term is used for a cluster of abnormal cells, and the benign tumor does not contain cancerous cells, while the malignant tumor contains the cancerous cell, and pre-malignant contains abnormal cells that have a potential to become cancer. So, what is a benign tumor? So, they won't invade the surrounding tissue or spread elsewhere. Even so, they can cause serial problem when they grow near the vital organs, especially in head and neck. They can press a nerve or constrict a blood vessels. And these tumors usually respond well to the treatment. So this is a case scenario. A 18-year female student of 8th standard came from Singrauli with a progressive enlargement of the left cheek, left-sided nasal obstruction, and mass. And she had this complaint for past 6 months with insidious growth, and there was a only nasal obstruction. She doesn't have very severe epistaxis, something like that. And when we saw, so there was a externally it was not much abnormal, only there was swelling of the cheek, and we could see the polypoidal mass present in the left nasal cavity, which was non-tender, does not bleed on touch. And there was also bulge present in the hard palate. So, what was this swelling at this age? This was a very discussing this. On CT scan, we saw bony swelling involving the maxilla, nose, and it was mainly predominantly present on the left side with this ground glass type of appearance. This is the second swelling of the tumor of the nose, this paranasal sinus, and this patient came with the history of 2 years. He came with a complaint of swelling and apiphora. So this was a CT scan picture. You can see this tumor was having connection to the eye with only slight erosion of the maxilla. So this was basically on investigation, benign adenoma arising from the lacrimal glands. So this was again a patient, 37-year-old male laborer, coming with a right infraorbital swelling. He didn't complain of any visual disturbance. Now this was a very unusual presentation of a small girl who had twice excision of this mass before coming to our medical college. So what is the provisional diagnosis of this unusual presentation at various age group? That's what we'll be discussing. So this is the classification of benign tumors of nose and paranasal sinus. This is WHO classification 2017, and mainly it is dominated by sinonasal papilloma, which can be an inverted type, oncocytic type or exophytic type. There can be respiratory epithelial tumor, mainly adenomatoid hematoma. There can be salivary gland tumor, or it can be a benign tissue tumor, leiomyoma, hemangioma, schwannoma, neurofibroma, as it can occur at any other site. Among the differential diagnosis of swelling, sinonasal ameloblastoma also comes under this heading. So, very adjacent to nose is the nasopharynx, and their benign tumor can also protrude into and present like a PNS tumor, and that hairy polyp, ectopic pituitary adenoma, craniopharyngioma, soft tissue tumor can come. So, I will not be covering them, but just for your sharing it, that these can also present as benign tumor. So, this was a classification which I took from Cummings. In Cummings, they have included juvenile angiofibroma also. So this is an inverted papilloma, Inverted papilloma is a benign epithelial growth in the underlying stroma of nasal cavity and paranasal sinus. Incidence is of approximately 0.6 cases per 1 lakh population per year, and it is the second most common benign tumor of sinonasal tract after osteoma. So these are the various synonyms. You might call it by inverting papilloma or Schneiderian papilloma. So it was first described by Watt, and Ringer's classically described the histological picture that there is inverted nature and the epithelium glows in the underlying stroma. The other variants are oncocytic and exophytic variants. So it is male to female ratio is 3:1, affect the patient between 5th and 6th decades, and mostly it is unilateral. Bilateral lesion occurs in 4.9% cases. The symptoms are unilateral nasal obstruction with watery rhinorrhea. There can be sometimes bilateral obstruction complaint. There is a nasal mass, sinusitis, and the orbital symptoms of epiphora, diplopia, and proptosis. Headache is associated with advanced lesion involving either the orbit or the skull base. So the commonest site is maxillary sinus, followed by ethmoid, sphenoid, and frontal sinuses, and it is associated with malignancy. So in 3.5 to 9.7% cases. So it can be a synchronous and case. Metachronous can also be there, and it can present like a small foci or squamous cell carcinoma within the inverted papilloma, or there can be a independent patient may present malignancy as a separate lesion. So the cause is unknown, but the Schneiderian membrane is the tissue of origin of the sinonasal mucous membrane, and from that only the inverted papilloma grows. There is various etiological confusion whether it is allergic related or whether it is related to rhinosinusitis, but it can be a sequelae. Rhinosinusitis can also be a sequelae to inverted papilloma. Similarly, there is a prevalence of human papilloma virus association, and human papilloma virus 6 and 11 are associated. However, when the serotypes 16 and 18 are present, there are more chances of malignant transformation of this inverted papilloma. Grossly, it appears as exophytic, polypoidal, and vascular tumor. It is pink to gray with fawn-like projections extending from the main bulk of lesion, which is usually arising from the lateral wall, and the rest of the sinonasal mucosa is normal. When you do probing, it is appeared to be arising from the lateral wall. It may bleed on touch, and usually it fills the nasal cavity. It can be seen through the anterior rhinoscopy. Histologically, it is the epithelium can be squamous or respiratory. The epithelium of tumor appears to be proliferative. It is but different from the surrounding tissue as it lacks the mucus secreting cells and eosinophils. The nuclear cytoplasmic ratio is within normal limit, and squamous metaplasia can sometimes occur. So this is the endoscopic picture. You may confuse it with a normal polyp or other nasal mass lesions. And this is again typical endoscopic. You can see the typical forms of growth protruding, papillary forms protruding from the middle meatus, and it fills extensively the nasal cavity. It may sometimes bleed when you do probing of the cavity. So you can see the hyperplastic bands growing endophytically into the underlying stroma, and the epithelium is multi-layered form of squamous or ciliated epithelium. So diagnosis, you will do an anterior rhinoscopy, you will do a nasal endoscopy, and then you will see the growth arising from the middle meatus. It can be extensive or limited. You can take a biopsy from the lesion, which is looking like a papillary protrusion, and the typical histological arrangement of the fawns characterized by parallel folds made of highly cellular metaplastic epithelium and underlying less cellular stroma in which the epithelium is invaginating or growing down. So that is typical, and that's why it is known as inverted papilloma, like papillary growths are going down into the stroma. So imaging is must. It helps us to know the three-dimensional growth configuration and also the relationship to the important skull-based structure like optic nerve, orbit, skull base, and you have to order a CT. In CT, you can see the bony erosion, and however, it is usually present in the malignant tumor is associated. So bony remodeling will be the better term to describe the changes that occur secondary to constant pressure and mass effect on the surrounding tissue. We can see order a contrast CT and it demonstrates slight enhancement and calcification. The typical inverted papilloma appears hypo-intense on T1 weighted and iso to hyperdense on T2. It helps to differentiate tumor mass from obstructed secretion. So this is the typical picture of the inverted papilloma originating from the middle meatus. Again, you can see in one of the CT scan. And here you can see the typical picture. This is a cerebriform columnar pattern of the lesion which is described in CT scan, and it permits visualization of the bony spur. See, this is the bony spur along the lateral wall where this lesion originates. And the CT is sometimes the CT scan does not provide good characterization, but it is helpful in knowing this bony detail. So while doing surgery, you have to remove the mucoperiosteum and drill this area if you want prevent the recurrence of the tumor. So this is a typical sclerotic bony spur which is identified on CT scan. So radical excision by doing medial maxillectomy through the lateral anatomy approach was very popular in 20th century. Now only which was gradually replaced by mid-facial degloving approach, and then the endoscopic approach became popular. We'll be discussing the approaches soon. So advantage of endoscopy is there is no facial incision, negligible post-op swelling, shorter inpatient time, and reduction in post-operative pain and dysesthesia. While contraindication to endoscopic approaches, involvement of frontal sinus extensively or supraorbital cell, transorbital extension, concomitant presence of malignancy in the critical areas, and presence of significant scarring. Like if it is a revision case, then endoscopic approach may not be very appropriate if it is involving the lamina or orbit area. So there was a Krauss staging system for inverted papilloma. So what is T1 stage? T1 is tumor isolated to one area of the nasal cavity without extension into the paranasal sinus. T2, tumor involves the medial wall of maxillary sinus, ethmoid sinus, or the osteometal complex. T3, tumor involves the superior, inferior, posterior, anterior, or lateral wall of maxillary sinus, frontal sinus, or sphenoid. And T4 is extrasinonasal extension or malignant tumor occurring in inverted papilloma. So, for T1 stage, tumors may be resected endoscopically without much bone removal. T2 require more bony excision. You have to excise the medial wall. T3 tumor may be resected endoscopically if we can visualize, or an open medial maxillectomy may be required. And T4 may necessitate maximum exposure we require, so it can be an extensive approach. So type 1 resection is indicated for inverted papilloma that involves the middle meatus, ethmoid, superior meatus, sphenoid sinus, or combination of these structures. Type 2 resection corresponds to endoscopic medial maxillectomy, is indicated for tumor that originate within the nasoethmoid complex and secondarily extend to either the maxillary sinus or into the anterior lateral wall of the sinus. And type 3 is also known as Sturman-Canfield operation or endonasal Denker operation. It entails removal of medial portion of anterior wall of maxillary sinus to enable wider exposure of the tumor. So this is what we do. This is the for type 1 resection. You remove the osteometal medial wall of the maxilla. In type 2, you remove extensively the inferior turbinate. Again, extensive remove middle wall up to the frontal sinus. And in type 3, you also remove the anterior wall of the maxilla like in Denker's operation. So, if there is frontal sinus involvement, then you will be doing draft 2B or draft 3 endoscopic sinusotomy or a combination of endoscopic approach with external sinusotomy through an osteoplastic flap depending on the extent of the frontal sinus mucosa involvement. Now we are coming to the different class of tumor. These are the fibro-osseous lesion. So there are three distinct lesions which occur in paranasal sinuses and also in the body, but typically here, so these are osteoma, which is a commonest tumor of paranasal sinus. Second is fibrous dysplasia, and then the ossifying fibroma. So although their appearance and presentation may be somewhat similar, their clinical implications vary tremendously. So this was a young female from a tribal area. She had a swelling of the cheek. She got some herbal treatment done. Even she got a tattoo and she presented to her OPD with a bony swelling of the left maxilla. Similarly, this boy came with the infraorbital swelling. So we are first discussing osteoma. Osteoma is the most common tumor of paranasal sinus with frontal sinus commonly involved, more common in male. Second and third decade is the commonest age of presentation and most lesions are benign. It is a slow, steady, progressive growth pattern. It may result in local infiltration or cosmetic change and it can cause obstruction leading to sinusitis and recurrence is very rare. And sometimes the osteoma may be a part of Gardner syndromes, which is an autosomal dominant disorder characterized by multiple osteoma, soft tissue tumors such as epidermal cyst, and colorectal polyposis. So here you should do a polyposis coli gene identification on chromosomal 5q. And early diagnosis is crucial as this colorectal polyposis can become malignant. So what is the etiology of osteoma? A developmental theory tells that apposition of endochondral and membranous tissue traps the embryonic cell leading to osseous proliferation and this explains the osteoma of the frontoethmoidal suture. However, we get osteoma elsewhere also. So the second theory is traumatic theory in which they tell the inflammation which follows trauma is leading to the osteoma formation. The third theory is infectious theory. Again, however, none of the theories are completely explaining the disease. So what is the pathology? There are three types of osteoma. They may be a sessile or pedunculated type and they are usually covered by sinus mucosal. Now they can be eburnated type, also known as compact type. It consists of dense bone and lacks the hibernation canal. The mature type is composed of cancellous bone and then there can be a mixed variety of both types. So location-wise frontal sinus is very common and the symptoms results from mass effect. Patient may complain of frontal pain and headache, sinusitis secondary to obstruction, or there can be mucosal formation. So on radiology, you get a dense, homogeneous, well-circumcised mass, both on CT and plain X-ray. There can be thinning due to mass effect, and MRI should be done when you suspect intracranial extension, and as it helps to differentiate sinus secretion from mass lesion or brain parenchyma or orbital tumor. So this is a typical compact type of osteoma. It is invading the orbit, displacing the optic nerve, superior oblique muscle and inferior rectus muscle. The high and quite homogeneous density is characteristic of ivory variant. So students, I would like to tell that few images I have taken from some articles of radiology because they will give a proper impact that what can be the sequelae of this benign tumor as they can involve the optic nerve and superior oblique. So these are the cases where you have to do a treatment although they are benign lesions. Similarly, you can see an osteoma in the ethmoid and frontoethmoidal area. So this is the compact one and this is the cancellous type. So you have to remove them. Now what is the management? Osteoma, if it is a very small, you do a periodic follow up at 6 months. But if it is at the critical area obstructing the drainage, or if you think it is a very big, it can cause the posterior wall of the frontal sinus, then you have to do a surgical resection for large symptomatic tumor. So what are the indications for resection? For rapid growth, infection, compression of vital structure, severe pain, facial deformity, vision changes, mucosal formation, infraorbital intracranial extension. Now, a tumor who is occupying more than 50% of the frontal sinus needs to be removed, or if it is a posteriorly based lesion, then you should remove. Now you can do an external approach or endoscopic approach, or you can combine the two. The goal of surgery should be the complete removal of the tumor with minimum damage to the surrounding mucosa. So choice is endoscopic. You can do a draft 2 and 3 procedure and remove the frontal osteoma, and most lesions that are either anteriorly based or located lateral to the sagittal plane of lamina papyracea should undergo an open osteoplastic procedure. Open approach can be linked frontal frontoethmoidectomy, or it can be osteoplastic flap. So we can do a combination of the procedure, or you can do a small trephination with the endoscopic approach. So what is the grading system for frontal sinus osteoma? Grade 1 is tumor base of attachment is posterior inferior along the frontal vessels. The tumor is medial to a virtual sagittal plane through the lamina papyracea. So if it is medial to the sagittal plane, it is easy, and the anterior posterior diameter of lesion is 75% of the anterior posterior diameter of the frontal recess. In grade 2, the tumor base of attachment is posterior inferior along the frontal axis. Tumor is medial to the sagittal plane through lamina papyracea, and more than 75% the lesion diameter of the anterior posterior lesion. Grade 3 is tumor attached either anterior wall of the frontal sinus or superiorly within the frontal sinus, or it extends into the plane lateral to the lamina papyracea. And grade 4 is tumor fills the entire frontal sinus. So, what are the symptoms? It can lead to clinical indication for surgery is frontal osteoma adjacent to frontal sinus. There is rhinosinusitis, chronic headache, cosmetic deformity, meningitis, or displacement of eyeball. So endoscopic resection is done for grade 1 lesion. Grade 2 may require trephination for an above and below type of approach, and grade 3 and 4 require an with external approach. So this is the logic what I am explaining. If the tumor in grade 1 and 2, see it is lamina papyracea, so any tumor located here is approachable endoscopically, but if it is here or on the anterior wall, like in anterior wall, so endoscopic approach becomes difficult. So this requires some external approach to be supplemented. So this is the draft procedure, type 1. This is a type 2 draft, and mostly you require type 3 if you want to approach the lateral lesions. Now this is the osteoplastic flap method. You take a bicoronal incision, elevate it along the, give the incision along the hairline so there is no cosmetic deformity, elevate, remove the osteoma, and you make the drainage of the frontal sinus patent. So this is the technique of osteoplastic frontal sinus surgery. You can do drilling, you can use a cut. So these are the procedures. Now elevation of frontal sinus anterior wall with 2 broad chisels. This ends in fracture of frontal sinus floor just posteriorly of the supraorbital ridge. So these are the various combination of methods. This is again how you can open up like a flap and then you can remove it. So what are the complications? You can injure the orbit, optic nerve, or skull base. CSF leak can be encountered, so you have to repair it, and there can be reactive bony hyperplasia secondary to it, or there can be mucosal secondary to it. So you have to keep the patient under follow-up and take the CT scans. Now fibrous dysplasia is the second most important lesion of this area. It can be found in and around the paranasal sinus. Fibrous dysplasia are of 2 types, the monoosteotic and the polyosteotic. You all know the commonest type is the long bones or rib, But in head neck, it is commonly, so this was a case of fibrous dysplasia in which we removed it. It was extending far down, so a huge globular swelling present on the premaxilla, 10 to 12 centimeter in dimension. Mouth opening was adequate, hard palate bulging was present, and it was blocking the nasal cavity and pushing the lateral wall, the septum towards the right side. There was blockage of both nostril. It was hard in consistency, and the history was almost of 5 years duration. So what are the monostratic fibrous dysplasia? They are in 70 to 80% of the cases involve one bole. Monostratic form involves the facial skeleton in 25% of the cases, and mandible maxillar common side. The polyostotic form can be a part of McCune-Albright syndrome, in which there occurs precocious puberty in girls, abnormal skin pigmentation, and early bone maturation. So the risk of malignant transformation in polyostotic form is 0.5%, and in McCune-Albright syndrome it is 4% risk. So what are the symptoms? There can be bone pains, bony deformity, fracture, facial asymmetry. The symptoms are facial asymmetry, vision defect, hearing impairment, nasal obstruction, paresthesia, and sometimes malocclusion. Now, the disease usually has an indolent course. When adjacent structures are affected, it presents as lacrimation, loosening of tooth, proptosis, cranial nerve palsy, nasal area obstruction. In young children and adolescents, it may present with a rapid growth with cortical expansion and displacement of adjacent bone. Rapid growth may be associated with generous bone cyst, mucocele, or malignant transformation. However, after puberty, it stabilizes and then you can treat the lesion. So biopsy may not be always warranted. You can make a diagnosis on the basis of the ground glass appearance, and it usually presents in younger children with the growth actually decreasing with the puberty. And because of you can do a conservative treatment, or you can do a limited surgical resection. So for a cosmetic deformity if it's involving the cheek. So this is a limited fibrous dysplasia seen in the ethmoid sinus. An expansor can be right away with a ground glass appearance. This pattern reflects a different degree of mineralization of fibrous tissue that is replacing the normal bone. The lamina papyracea is interrupted here, but the orbit is not involved, and the cribriform plate is thickened. So what is fibrous dysplasia? The normal bone is replaced by fibrous collagen tissue with irregular trabecula of bone. This is a typical case of the infraorbital swelling. There was shifting of the eye, but he was not, since it was a slow growing fibrous dysplasia, the patient was not complaining of any significant vision loss. So there was a infraorbital swelling. The radiologically you can see there was a huge mass involving. So when you remove it, it can come, you can take the margins and remove it as a complete block. You can remove it, and external approach is required for such a big tumor. So what is the management protocol for the fibrous dysplasia? When the patient comes to you with swelling, you investigate the patient with CT scan, and on CT you can make out. Biopsy may be required if this lesion is so much big before planning a treatment. And if a patient is complaining of his fracture in the last 1 year in the polyostotic form, you can start a biphosphonate therapy, or pamidronate can be started in this doses. Intravenous zoledronate is also given once yearly, or alendronate, zoledronate are the various treatment modalities. Now the disease may involve the sphenoid, orbit apex, frontal bose, and then it can cause proptosis, visual disturbance, orbital dystosis, and now this is the tumor of fibrous dysplasia. You cannot wait, as it can lead to blindness. And we have seen a young girl coming with front ethmoidal, posterior ethmoidal fibrous dysplasia, and this patient usually was she landed up into blindness. So we did surgery with the neurosurgeons. we removed the posterior ethmoid and the sphenoid. This is a different case. Here we have removed the mass by Weber-Ferguson incision and the full mass came out. On histopathology, typical features of fibrous dysplasia is seen, in which collagen tissue and bones with irregular, not thick mineralization. Oh God, I'm so sorry. I'll be. So these are the tumors which can present with the disease. Uh, Now, ossifying fibroma is the third lesion that can be known as cementifying ossiforma or aggressive ossifying fibroma. And these tumors are having, this is a challenging tumor which can present with a differential diagnosis from the fibrous dysplasia. So radiologically, ossifying fibroma appears as a well-circumcised region with axial rim and central lucency, whereas fibrous dysplasia takes on its characteristic ground glass appearance. Ossifying fibroma presents as expansile lesion with a definite demarcation from the surrounding bone, while fibrous dysplasia has a more diffuse margin. Histologically, fibrous dysplasia lacks the peripheral osteoblast and lamellar bone that the ossifying fibroma presents. So, ossifying fibroma can be locally erosive and very destructive. While these lesions are most commonly found in mandible, even more aggressive when located in other locations such as paranasal sinuses. So, due to destructive nature of these lesions, we have to do a complete resection via the external approach. It was done in past. However, the lesion, if it is a very small lesion, you can do endoscopic resection, and endoscopy should be done for surveillance also. So this is how the ossifying fibroma comes out. This is a typical presentation of ossifying fibroma. Now these are the three lesions. This is the osteoma. This is the fibrous dysplasia not a very well demarcated area, and this is the ossifying fibroma with a well defined margin. Again, this was taken from a journal. So now I am coming to the respiratory epithelial adenomatoma. So it is a benign neoplasm occurring in the nasal and paranasal sinuses with prominence of submucosal granular proliferation, which is lined by ciliated epithelial cell. Common age is 6th decade and male-female ratio is 7:1. Patient present with complaint of nasal obstruction, rhinorrhea, loss of smell. They mostly are formed in anterior half of olfactory crest, and involvement of other size is less common. CT will show the clear enlargement of olfactory crest, and MRI fissure will be useful. So this is the typical presentation of the tumor in the olfactory crest, and MRI shows the well delineated mass. You can see the widening of the olfactory crest on the CT scan. So clinical diagnosis is dependent on widening of olfactory fossa, and the main differential diagnosis is inverted papilloma, which requires more extensive surgical excision, and while the REAHS requires a simple curative resection as no malignant transformation is reported. So salivary gland tumor, you can get adenoma in the nose, which takes origin from the, and it can present with a small tumor in the nose. 35 it is a pleomorphic adenoma arising in the nasal cavity. It is more common to 3rd to 6th decade, and it presents with nasal obstruction. It can present as a submucosal mass on the septum, and malignant transformation has been reported in 2.4 to 10% of the pleomorphic adenoma. On a multilobulated appearance is the key finding. It can cause bone displacement and remodeling, or sometimes calcification. So the treatment is you have to excise this completely. This is the adenoma present in a male, and you can do an excision. So because complete excision is curative, it is important to identify region of intranasal pleomorphic adenoma, and sometimes the myxoid appearance in the post-operative region may be the most frequent feature of recurrence. Now this is the hemangioma arising from the septum. This is the cavernous hemangioma or the dorsum of the nose. This is also known as pyogenic granuloma. So hemangioma, you all know, it is a benign tumor of vascular phenotype. It can be capillary and cavernous type, and it is easy to diagnose clinically. And capillary hemangioma, lobulated capillary hemangioma, or pyogenic granuloma composed of capillary sized vessels lined with flattened epithelium separated by collagen stroma. So they can occur in all ages. However, they are common in children and adolescent male. Now, cavernous hemangioma appear as multiple large cystic thin-walled blood-filled vessels. Now, what is the symptoms are epistaxis and nasal obstruction. They can arise from the septum, while cavernous originates from the lateral wall. You have to do a T2 weightage image in which you can see a washout pattern and non-enhanced thin peripheral ring characteristic of capillary hemangioma. And you can do pre-op embolization that decreases the bleeding. So this is a typical picture of the enhancement shown. Now this is the cavernous hemangioma in an elderly male. Again, this I have taken from a net. And these are the hemangiomas which require treatment in these patients. You can do embolization and then do removal of the tumor. So lobular capillary hemangioma is also known as pyogenic granuloma. It is a misnomer, and there is a rapid growth lesion characterized by proliferation of capillaries arranged in lobules infiltrated by lobule cells. And see, there can be history of trauma, hormone, viral oncogene. So when there are many theories, means no single theory holds true. So it presents as a red purple mass with epistaxis and obstruction, and differential diagnosis is various angiosarcoma, hemangiopersoma, hemangioma, angiomatous polyp, and other vascular tumors. You should be differentiated from the metastasis or from the kidney or thyroid. So radiology helps us to diagnose, and this is a lobular capillary hemangioma involving and pushing the brain, and so this requires a treatment. So these are the benign tumors in which CT and MRI plays an important role, and then they help us to do a post-op follow-up. These are the tumors you have to do excision. So histological only establish the diagnosis. Only biopsy you will get only a vague diagnosis. So this was our case in which we did embolization with secondary changes like this, and then we did a angiography which reported the blood vessel supplying was facial and the infraorbital, and we did preoperative mosalization. And this is what the reconstruction was done by forehead flap. This is a simple tumor. You can remove it with a bipolar cautery by applying it at the base of the tumor, and it's curative. However, don't forget to send every biopsy. Whenever you are removing an enterocorneal polyp with abnormal presentation, it can be an inverted papilloma behind the enterocorneal polyp or ethmoid polyp. So any nasal lesion biopsy you are doing or doing surgical procedure, don't forget to send the lesion for biopsy and see the post-op biopsy, do endoscopic correlation, as you have to do follow-up of all these benign tumor to show local recurrence, residual tumor, or a recurrence. So schwannoma, as you all know, originates from the myelinated nerves, and they can involve any part of the body. In nose, it involves the sinonasal tract, and it can be a part of von Recklinson disease. It can originate from ophthalmic and maxillary division, and this type of presentation can be there. And CT scan, you can get an Antony A cell and Antony B cell, and tumor immunoreactive for S100 protein. So CT findings are characteristic. We are not very characteristic, but you can get a mass. And this is how a schwannoma can present. There was also a hemangioma in this case of the soft palate. So this is the mass of the schwannoma. You can excise it and take a CT in follow-up period So radical surgery is treatment of choice. Similarly, you can get a leiomyoma, which is a smooth muscle tumor, and in most cases it involves the nasal cavity. You can get angiolioma. It is a differentiation from vascular leoma. There can be calcification of fatty metaplasia. Adults are mostly affected with female predilection. It presents as a long-standing polypoidal mass with nasal obstruction, epistaxis, and pain. So the inferior turbinate septum are the common site. Imaging, you can see a primary expansile growth rather than invasively or destructive. And the treatment is, this is a leiomyoma, and you can do see an elliptical well-defined expansile mass without bone erosion helps us to diagnose it, and you can excise it. So this is the differential diagnosis. I am not showing it completely. I have taken it from one of the articles. And this was our giant cell tumor, young girl. There was giant cell like aggregates of giant cell in fibrovascular stroma, characterizing this benign condition known as giant cell reparative granuloma. It arises from the maxilla, but it can present in the it arises from the upper alveolus, can present from the in the maxilla. So this girl was an athlete, and she correlated it with a trauma. So female is more prone to get giant cell granuloma. CT shows the typical soap bubble appearance with well demarcated edges, cellular stroma containing aggregates of giant cell. The lesions are benign despite presence of mitosis, which may cause inexperienced pathologist difficulty. And biochemical investigation should be done to rule out, differentiate from brown tumor of hyperthyroidism. You should do calcium alkaline phosphatase. This is the typical clinical appearance, soap bubble appearance of this tumor, and treatment is curettage, and you should do a follow-up. Meningoencephalocele this is the herniation of brain tissue. It presents with a pulsatile swelling, and you all are aware the cyst is not reducible, shows cuff impulse. Root of nose, side of nose, or anteromedial wall of the orbit is the common site. It can resemble a polyp. So never do a biopsy or just do avulsion. You should do a CT scan to see it from herniating from cribriform plate or foramen cecum. So don't do biopsy, and you have to do a craniotomy, remove the stalk. This is how the nasal dermoids can present with the hair over the dermal pit on the nasal dorsum, and you can have a dermoid cyst going inside. So these are the nasal fistula and cyst anterior to the frontal bone, and you should be aware of these cysts. And external pit is present, hair may protrude, the sinus tract communicates intracranially, and you require a neurosurgical approach. Glioma is again a nibbled up brain tissue, and there can be firm subcutaneous swelling near the side of the nose, and it can be removed by external approach. Chondroma are again various types of tumor, fibro, osteo, angiochondromas originating from the cartilaginous tissue, and ethmoid, nasal cavity, and septum present a smooth lobulated growth, and treatment is wide excision because they may become malignant. Hemangiopericystoma arises from the pericyte which surround the capillary into 60 to 70 years, and patient may present with bleeding. It can bleed on biopsy. The nature of tumor, whether benign, cannot be distinguished histologically. Treatment consists of excision. Ectopic pituitary adenoma can also present here. Now I'm not going into detail. It can present here. Other differential diagnosis is fungal ball. So students, here I am completing the discussion. Now if you want any uh, discussion or any questions, we can go ahead with the discussion part. I'm sorry, I was going a bit fast. Sir told me to stop the. So I don't think there is any question in chat box. Anyone, if you want to ask me something, you can ask me.
Dear trainees, you may unmute and ask your questions as well. You may use the raise hand option, or you can just type in chat box. Thank you.
So I think the students don't have any questions.
There are a few.
See, there are two things. You have asked me about pyogenic granuloma. So this term actually when it occurs in the oral cavity over the mandible or upper alveolus, so that time it occurs in pregnancy, and this pyogenic granuloma which I am telling, it occurs on the septum. So yes, this septal one which I have discussed today is not having any correlation to pregnancy, but pyogenic granuloma of alveolus is just, it is occurring more commonly in pregnancy, and mostly in dental books it is described very nicely. Yes, this specific PowerPoint is available with your host, and they will make share with you. If any questions you can ask me, because I have given a halt because there are many numerous small tumors which are occurring also in nose and paranasal sinus as they can occur in other parts of the body. But I'll tell you, pyogenic granuloma is very satisfying surgery. Don't do a biopsy, just do a probing, see the origin, and use a bipolar, and you can remove it completely. And immediate post-op also, you will not get much bleeding. Okay, so this melanoma is something which is a malignant tumor, bachcho. This is not a benign tumor. And if you are asking me about the nasal melanoma, so they are basically they will present as a discoloration or a growth in the nasal cavity. When you touch it, you will get bleeding, and these patients will have metastasis by the time you see. They can be a amelanotic variety, or it can be a pigmented variety. So when you see them, you have to take a biopsy in a amelanotic type. When you do endoscopy, you will be a bit confused with what type of it is. But once you see them, like once you take a biopsy, it comes out positive. But when it is a melanotic variety, clinically you can definitely make a diagnosis. They can be a alveolar arising from the upper alveolus going into the nose, or from nose they can involve the upper alveolus, because they are aggressive. Only 3 months history you get, and there can be metastasis by the time you see them. So I have not described melanoma because this is a malignant tumor. But still you want to ask me something, I can answer you. Or you are asking me leiomyoma or something like that.
Dr. Shubhankar, you may ask your question.
Good evening, ma'am.
Good evening.
Ma'am, like in Viva, when we are asked this very commonly that what are the DDs of nasal mass, ma'am? So,
Yes.
what is the systemic approach to this type of question in Viva, ma'am? Like we all know the answer. Like how should we frame it, ma'am?
Nasal masses.
Yeah, yes, ma'am.
So this is a very beautiful question. You can always go with the classical description that they can be a congenital, they can be inflammatory, there can be traumatic, there can be tumor like. Okay, so in tumor you will tell them as a benign or a malignant tumor.
Malignant.
Right. So always whenever any question is floated to you, always start like that, that there can be a congenital से लेके malignant तक आप जाइए. Inflammatory डालिए, traumatic डालिए उसमें. ठीक है?
Ma'am. Right, ma'am. Right,
And you can describe in one more way that whether it is a unilateral mass or a bilateral mass. In everything you can describe it like that also. Unilateral or bilateral presentation.
Right,
external to nose, internal to nose, like that.
Ji, ma'am. Thank you, ma'am.
So this is a very rare thing, and benign tumors you will see very rarely when you will be practicing. Then once in 6 months you will get a benign tumor. Like I showed you a figure of a lady, they will come with a 5 years history, and they will do a shopping of doctors. They will go from one doctor to other. So if you know that this can be a benign tumor, you can convince the patient and discuss the treatment plan with them there and then only. There is not much role of sometimes biopsy. You can make a diagnosis on a CT scan and then explain. Like if you are seeing a inverted papilloma, so you can see it on the CT and all, and then you can tell this appears like a tumor, but I have to go do a more radical, like you have to do a removal of the bone and remove the mass, and then you can tell there is possibility. So once you talk to the patient and you explain them beforehand, then they trust you more. So I will just like to ask you students, like we also want to know what is the feedback, whether it is useful or you would like to have some other way of presentation. Okay, you are asking me about AC polyp associated with any syndrome. So basically, when you have a immotile cilia syndrome, then you get more of rhinosinusitis, and in that case, you can get a AC polyp. But AC polyp is not associated with any syndrome. What I discussed was a osteoma associated with colorectal polyposis. So should I go back to the slide, or you will see it on the site?
Yes, please. We have time. You may
I
share
may
the
go
screen
back
again.
to explain them.
Yes, please.
Okay, so I am again going back. So to the question he has asked. So can you speak out what you want to ask again, student?
Dr. Yuvraj, you may ask a question. Dr. Yuvraj? So dear trainees, we still have a few moments. You may type your questions, comments in the chat box, or you can just use the raise hand option so that I can give you the access to unmute and ask you questions. Thank you.
So I have skipped a classification. If we have time, I will share it.
You may please share the screen again.
Right. So I have just went past because I thought the time is going out. So this was a slide which I would like to share. So this is a classification of what are
No,
the
no, the
benign
share is
lesions.
the screen. The you have to share. Click on the share option. Select screen one and share. We are not able to see the screen.
Okay. So share. So this was the so this was the screen which I wanted to share between the different things. Like you can get various vascular tumors, benign tumor mass, like angiolioma, which is more common in male, It arises from the inferior turbinate and nasal septum and nasal vestibule. There is no change in adjacent bone, and on CT you will get a heterogeneously hyperintensity, and there is remarkable enhancement in the flow void is not present. Similarly, capillary hemangioma is more common in children, more common in male sex and in reproductive years, and it arises from the nasal septum. There is no change in adjacent bone, and it appears like heterogeneously and hyperintensity with hypointense peripheral. There is remarkable enhancement with a washout pattern in capillary hemangioma and non-enhancing peripheral ring, and there is a flow void present in the surrounding and the intratumoral mode. While in cavernous hemangioma, it is more common in male. It arises from the lateral wall of the nasal cavity. There is no adjacent change in the adjacent bony wall, and there is hyperintensity in T2 weightage image, and there occurs progressive enhancement. While schwannoma is common in male and female, it can arise from the nasal cavity or ethmoid sinus, and there occurs smooth erosion and scalloping of the adjacent bone. The target sign, that is the peripheral hyperintensity with central hypointensity, is present, and there is remarkable enhancement due to poor venous drainage. While nasopharyngeal angiofibroma, you all know, is exclusive to young male, arising from pterygopalatine fossa with anterior bowing of the posterior wall of the maxillary sinus, and it is in T2 weighted image, it is iso to hyper intense, and there occurs remarkable enhancement present, and flow void is present in this tumor. Excuse me. So this is what I think most of the important one I have completed. And sir, I think the time is, if they want, I can discuss the dermoids, which I have skipped past. But only if they are interested, I'll share.
We still have a few moments. You may continue.
Okay. So dermoid cyst of the nose, basically a small children come to you with a swelling on the dorsum of the nose. So there is a small midline swelling over the nasal bone, and when it is inside the nose, it doesn't have any external opening. Or dermoid cyst can present with a sinus, that is the external pit, in infant and children, and it can present as a sinus over the dorsum. Hair may sometimes protrude out, and then you should think that there can be an intracranial connections. The sinus tract may communicate intracranially, and usually the cyst lies between the nasal bone and the upper part of the nasal septum. So you do a treatment. Surgery consists of splitting the nasal bones and removal of cyst along with its extension in the upper part of the nasal septum. Now, intracranial extension, if there is present, you should take a help of neurosurgeon. Similarly, glioma are the nipped off portion of encephalocele. It is present develops during embryonic development, and they are extranasal. So other types can be intranasal. There can be intranasal glioma, or there can be both intranasal and extranasal glioma, usually present in small children, like a swelling over the nose, and external gliomas are usually encapsulated. So they present like firm subcutaneous swelling, may be seen on the nasal bridge or the side of the nose or near the inner canthus. Now treatment is done by removing by external approach. Chondroma can be mixed, fibrous type, osseous type, or angiochondromas, and histologically differentiation is not very clear cut. The common site of origin are either ethmoid sinus, nasal cavity, or septum. Wherever there is a cartilage, you will get a tumor, and they present as a smooth, firm, lobulated growth. Treatment is usually wide excision because of their tendency to form chondrosarcoma or malignant tumor. And hemangiopericytoma is a tumor which is arising from the pericyte, typically surrounding the blood vessel. It is common in the nose but may involve the sinus, And clinical features are elderly patient between 60 to 70 years, patient present with epistaxis. If you take a biopsy, there will be brisk bleeding. The nature of tumor, whether benign and malignant, cannot be made on histopathology. You have to do an in toto excision, and radiotherapy is only for extensive or recurrent lesions. Now, ectopic pituitary adenoma is a benign anterior pituitary gland neoplasm that does not involve the sella turcica. Patient age at presentation varies between the first to 9 decades of life with more of female prediction. Symptoms may include nasal obstruction, sinusitis, rhinorrhea, discharge, and headache. Such patients can have endocrinopathic manifestations. About 70% of endocrine are functional, including Cushing's syndrome, acromegaly, or hyperthyroidism, as these tumors may be hormone secreting tumors. So it is most commonly occur along the path of Rathke's pouch, and especially in the sphenoid sinus. Imaging studies are required to exclude the direct extension from sella turcica. CT shows a well-defined lesion and bone destruction is common while calcification is rare. You can do an MRI imaging to know the disease, and this is how you can get the lesion in the nasopharynx or in the sphenoid. So other differential diagnoses are fungus ball. It can present as isodense lesion with partial calcification in the sinus. The other is AC polyp, which can present as a benign tumor. Then granulomatosis with polyangiitis. This is a granulomatosis with polyangiitis in a 59-year-old male. CT shows hyperosteosis of the maxillary sinus, and coronal image shows destruction of nasal septum and mucosal thickening of the maxillary sinus. So this can be one of the differential diagnoses. Now, expanding hematoma in a 70-year-old man, it shows a hyperintense dense mass in a right maxillary sinus with expansion of the sinus walls, and dynamic contrast enhanced fat suppressed T1 images show a gradual heterogeneous enhancement pattern. So this can also be one of the differential diagnoses. So summary based on the imaging feature, like inverted papilloma will show focal hyperostosis of the origin of inverted papilloma on CT, and a convoluted cribiform pattern on T2 weighted and contrast enhanced T1 weighted image. While adenomas typically shows enlargement of olfactory cleft without bone destruction. Capillary hemangioma, hyperintensity on T2 weighted image with remarkable contrast enhancement with non-enhancing peripheral ring. While cavernous hemangioma show hyperintensity on T2 weight image with progressive enhancement pattern. While nasopharyngeal angiofibroma will show the anterior bowing of the posterior wall of the maxillary antrum with flow void in young male, while fungus ball shows a hyperdense mass with calcification, and chronic expanding hematoma will show a mixed variable signal intensity, both T2 weight and T1 weight. Now students, this one thing you should think why this slide is important, because most of the benign tumor will present with swelling, nasal mass, bleeding, and with endoscopy, a CT scan which is showing you a expanding lesion, not a erosive lesion, helps you to make a diagnosis of a benign lesion, and differential diagnosis within benign lesion depending on the features. Here, most important thing, you should have a good friendship with your pathologist and radio diagnosis. Pathologist will help you to make a clear-cut diagnosis between whether it is a fibrous dysplasia, osteoma. Similarly, imaging feature, if you have a good radiologist as your friend, he will help you in making a diagnosis and making you help how to plan the management. So now odontogenic tumor was left. In that only I would like to tell you about the benign tumor which may mimic a benign tumor. So diagnosis depends on the precise histology. Now here ameloblastoma I would like to tell. There are various odontogenic tumor which may mimic a benign tumor of the maxilla. So calcifying epithelial odontogenic tumor, ameloblastic fibroma, ameloblastic fibrodentoma, complex odontomes, or dentigerous cyst, or odontogenic myxoma. So this is the site on the jaw where it can present ameloblastoma. It can present in the jaw, upper and lower, and 5 to 5% of uniocytic ameloblastomas you can get. The term should be reserved for a well-defined monocystic lesion with lining focally composed of ameloblastic epithelium. The inner surface of cyst lumen may show one or more polypoidal pedunculated masses. Type 1 and 2 tend to be dentigerous relationship, although on removal the uninvolved tooth displaced by the cyst rather than projecting in the cyst. So, maxilla and mandible is having 1:5 ratio. It involves the young adults, and usual presentation is painless swelling. Pathogenesis is controversial. However, ameloblastic transformation of reduced enamel epithelium is now why I am including it into a benign cyst, that if you are not doing a proper excision of ameloblastoma, there will be recurrence with expansion into the surrounding tissue, and then it will require a very extensive excision like a malignant tumor. So radiographically, you can see ameloblastoma, and the treatment usually consists of enucleation and curettage if it is very small, but if a big, you require to be very complete removal with alveolus or the mandible or the maxilla. So multicystic is the conventional ameloblastoma. It is common, it is benign, but locally invasive growth with high recurrence rate. It is derived from dental lamella. Trigger factors don't know. It commonly involve the molar area, and common age is 37, and clinical signs may be facial deformity, loosening of tooth, axial crackling, spontaneous jaw fracture. Radiologically, you will classically see a honeycomb appearance, which has to be differentiated from giant cell lesion, and scalloped margins are seen with typical resorption. Histologically, the lesion consists of odontogenic epithelium with fibrous stroma. So tumor infiltrates within the cancellous bone, leading to poorly defined margins. The preferred treatment is en bloc resection. Since cancellous infiltration may extend 5 mm more beyond the radiological limits, you can a conservative approach is curettage, burying of the bone, followed by filling the cavity with bony chips, or you can do a radical excision. You can get a OPG, or you can get a CT scan, or you can do a facial reconstruction to know the extent. Now there are various cysts of the maxilla. These cysts may mimic a benign tumor. So nasal glioma and cephalocele are located here. There can be a lateral canthal dermoid mimicking a benign tumor of the paranasal sinus. There can be a nasolabial cyst, which is in the anterior wall. It can be a dentigerous cyst. It can be globulomaxillary cyst or nasopalatine cyst, which occurs at the fusion of the palatine process of the alveolus, and this can present as a bulge in the nose or the bulge coming from the lateral wall of the nose. And X-ray, simple X-ray will help you to make a diagnosis. So dentigerous cyst is eruption cyst. So I will not go into detail. You should be keeping all these cysts in the differential diagnosis, and you have to remove the cyst completely along with the dentist. So now I am closing the presentation. So this is the typical lesion for nasopalatine cyst. This is the area for globulomaxillary cyst, nasolabial cyst, median palatal cyst, and here you can get the cyst. So now I am closing the presentation, sir, with your permission.
Sure, ma'am. So
Again, if they want to ask something, they may ask me, because then I'm having many slides of juvenile angiofibroma, but it comes under the tumors of nasopharynx. So I have not included it because it itself, or students, if they want, I can complete this part also. You can have their consensus, sir.
So any more questions, trainees? So if there are none, thank you very much, Professor Dr. Kavita Sachdeva, for the presentation, and thank you very much, trainees, for joining.
Thank you so much, sir, for interacting with the students, sir. Thank you so much.